Is there a disproportionate level of young Aboriginal and Torres Strait Islander people contracting sexually transmitted diseases? Why is this issue so prevalent? And has it always been this way? Why are rates rising? In determining answers to these questions, studies have been conducted and deep-seated social issues have been observed. Within Australia, there are currently residing over 700,000 Aboriginal people who represent 3% of the total Australian population. For this discussion, I am going to narrow down the population and focus on one particular subgroup: Aboriginal adolescents between the age of 15 and 29, currently living within rural Indigenous communities in Western Australia. To provide an overview, research conducted using surveillance data indicated that during 2013 and 2017, notification rates of chlamydia, gonorrhea, and syphilis escalated to between 3 and 11 times higher in Aboriginal people compared against non-Aboriginal people. This data provides statistical evidence towards Aboriginal vulnerabilities within sexual health. The issue remains: STI rates are rising, and more young Indigenous people are being directly affected. These are deep systemic issues within these communities that need to be addressed in order to overcome this rate of declining healthcare. How did we get here? A diverse range of social inequalities have forged the path in creating barriers and preventing change. At the forefront of this issue is limited access to healthcare, education, and sociocultural disadvantage, poverty, substance use, and gender inequalities. Access to healthcare is one of the most critical social determinants needing to be addressed. While healthcare as a whole is important, the lack of access to sexual health services is at the forefront. Without proper testing facilities and clinics open to young people, it creates a barrier to not only the conversation but frequent checkups. Many STIs can lay dormant with no symptoms, but have lasting ramifications if not treated. Sexual clinics offer educational opportunities and direct communication to the patient, whereby the person can gain information of preventative measures to reduce STIs, like contraception. Without these clinics, it creates an educational disadvantage. Education regarding sexual health is not limited to clinics. It can be taught in schools and through community programs. However, these rural communities are without effective educational programs. Research into these communities have shown not only a low level of attendance to school, but a high proportion of students are leaving school at an earlier age, and often during times of peak sexualization. This subsequently results in a high rate of exposure to STIs, pregnancy, and fundamental to the point, a lack of information and education about the transmission of STIs. Barriers preventing behavioral changes are often directly linked to stigma, racism, discrimination, and a lack of conversation being had. Stigmas relating to use of testing and treatment services are often exacerbated in rural and remote areas due to distance, lack of trust in confidentiality, and sparse services available. With the limited resources available within these communities, there may not be an option for a gender-specific doctor, and testing for STIs can be intrusive and confronting task for some people, especially when conducted by someone of the opposite sex and different cultural identity. These can create uncomfortable environments and prevent an open line of communication between patient and healthcare worker. These issues can be linked to sociocultural barriers within Indigenous communities, which prevent the conversation of sexuality and sexual health due to the stigmas of shame and embarrassment. These discussions are often masked and can be detrimental to educating young adolescents on preventative measures to contracting STIs. In addition to educational barriers, limited access to resources of online information, which ideally could have acted as a substitute to visiting a health clinic and used anonymously. However, due to the lack of resources, this creates a preventable barrier. Interventions towards education and prevention initiatives are being introduced by the Department of Health to support accessibility and acceptability of culturally competent clinical services. These approaches are attempting to improve knowledge and skills in how to access and navigate the local health services. Educational programs in primary and secondary schools have been implemented to support young people in managing risks and encouraging positive health-seeking behaviors to help reduce the transmission of STIs and highlight the importance of regular STI testing once sexually active. While these offer a solution to school-based education, support is also required in non-school settings for young people not engaged in the school environment. Evidence suggests that community-led peer education can be an effective way of engaging young Indigenous people in STI prevention interventions, particularly in addressing some of the social and cultural barriers that are influencing poor sexual health in rural areas. Barriers need to be broken and change needs to happen.